So I would like to welcome our today's speaker for the Cancer Center Grand Rounds, Dr. Robert Miller. Dr. Miller is a board-certified medical oncologist and an informatician who is the vice president and medical director of the CancerLinQ initiative of the ASCO that he will present to us today. Dr. Miller earned his medical degree from the Medical College of Virginia and did his residency in internal medicine at the University of California in San Francisco and a medical oncology fellowship at Stanford. He worked in many different roles for ASCO, including being member of the board of directors for ASCO and multiple different committees, including the quality of care, clinical practice, cancer education committees, and more recently he joined ASCO as a full-time employee to run the CancerLinQ program, which I think is one of the most sort of innovative initiatives by any professional society. Dr. Miller?
Thank you very much, Laosh, and many thanks to Dr. Pustai and Dr. Sabbath and others for inviting me. It's really honored to be here and speak to you a little bit about CancerLinQ. And as mentioned, CancerLinQ is an initiative of the of ASCO. It's a big data health technology platform, an attempt to build a learning health system in oncology. And I've been honored to work full-time as ASCO staff for the last couple of years as medical director. And I want to share a little bit about that journey with you and talk a little bit about what we're doing and pretty much, I think, the opportunities we have for participation of Yale Cancer Center and others. And so as way of background, the problem that ASCO was trying to solve really relates to the same information management challenges that face cancer medicine today, the overwhelming amount of data in the context of the modern world and managing the data. And I want to talk a little bit about the vision of CancerLinQ as an extension of ASCO's quality portfolio. I want to describe the architecture and features and how participating practices and others can access the features of CancerLinQ. And I also want to spend a little bit of time, maybe at a more high level, talking about the challenges of big data, as well as the opportunities for real-world evidence, for harnessing real-world evidence to add to the database for cancer. And so as way of background, CancerLinQ is a wholly owned nonprofit subsidiary of ASCO. We're a 501c3. We are housed in the same offices as ASCO in Alexandria, Virginia. We have about 58 employees now, so we have a separate staff and governing board. And of course, ASCO is a professional society. The three pillars of ASCO's mission relate to research, education, and promoting cancer care quality. And so CancerLinQ is a complement to that by really focusing on the power of transformational data analytics to help ASCO achieve its mission. And so as way of background, the ASCO Board of Directors about 5 or 6 years ago now was inspired by the work that what was then called the Institute of Medicine about the learning health system. I must admit, when I first heard the concept of a learning health system, it sort of sounded like this high-level, unrealistic policy gobbledygook, and I wasn't sure how it played out practically. But I think it describes the way that medical care and science should be delivered in the real world, that we know is not happening, a system in which research informs practice and practice informs research, and there's this virtuous cycle where these things are prioritized. And this was something that sort of got the ASCO board thinking a little bit as they formulated a strategic plan in 2011 or so, and they basically tried to envision what will the world look like in about 25 years of cancer medicine? What are the priorities? And again, none of these things are particularly surprising, but they settled on these three ideas of first, that you need health information technology to transform cancer care, to manage big data. Second, the importance of precision medicine. And third, the overwhelming question of the value of cancer care. I'm not going to focus so much on the value issues, but acknowledge their critical importance. And so there's no question that we live in the era of far too much data. So this is a fairly well-known curve, but if you think about back in the 1980s, back when I was in medical school, there was the idea that you probably could manage patients based on clinical phenotype by 5 to 10 facts per decision. And that, of course, has increased many log here in the modern era with all the data through genomics and functional imaging and so forth. But what really hasn't changed is human cognitive capacity is always about the same. Our brains can only process a certain number of facts per decision. I think my brain probably can process fewer facts per decision than in 1985. But the point is that you need supercomputers and you need the power of big data to make sense of this volume of data. And the other phenomenon that, of course, is well known is the fact that since only a small percentage of adult cancer patients participate in clinical trials, the care experiences of the vast majority of patients are really lost. They're trapped in the era of paper records and now in the EHR era in electronic health record servers that don't talk to each other, and you can't learn from most patients because their data is not being captured systematically and being accessed. And so the ASCO board and the leadership asked the question, well, what if we, as a professional society, what if we, ASCO, were to take on the challenge of trying to aggregate data? What if we were to capture all of the everyday data that's generated in the care of patients and bring it into a single rapid learning network? And so the idea of CancerLinQ was born. CancerLinQ stands for the Cancer Learning Intelligence Network for Quality. And basically, the idea was that it's really the responsibility of the physician to be the ones to evaluate and improve the quality of care. Too often, we are losing control, that these tasks are being ceded to others who have access to huge administrative data sets, the insurers and claims and data sets and so forth. And really the future will depend on doctors controlling the data, because they will then be able to chart the trajectory of the profession and to be able to influence care, because they're the ones who best know this. And so ASCO was inspired to take on this task and build CancerLinQ. And over the next 4 or 5 years, and I won't go through all of these steps, basically we created some advisory committees, we built a business plan, we branded this as CancerLinQ. If any of you might have been at the ASCO Quality Symposium in 2012, we showed a prototype using entirely different software than we have now. We opened up submissions to an RFP in 2014. And again, just to be clear, ASCO is a professional medical society. We're not a software company. We got a lot of this wrong. First of all, it took far too long to get this off the ground. We were trying to do this in a very thoughtful, systematic fashion. The RFP was far overscoped. It was about 3 times more expensive than we knew we could deliver. So we shifted gears a little bit, and ultimately it wasn't until January of 2015 when we made a decision to go with SAP as our vendor, and CancerLinQ was launched. And the system really didn't go live for another year. So it was really not until January of 2016 where we started bringing in data for practices. And we had to, of course, position the system within a regulatory framework that was respecting of federal and state law and all regulations. And this was a paper that was published by Rich Shulsky and Cliff Hudis in 2014. And it really talked about the regulatory underpinnings of CancerLinQ. And so CancerLinQ, of course, has to be compliant with HIPAA and HITECH and the Common Rule. But the idea is that since HIPAA permits the disclosure of protected health information for what they call TPO, treatment, payment, or operations, then this was the mechanism by which we could collect patient information into the system and use it primarily for, the first pass would be for quality improvement and improving guidelines. This was a carefully considered legal opinion. We sought the advice of several outside counsel, and we actually submitted this to an independent institutional review board asking the question, does CancerLinQ constitute research? Because if it did, then that would mean that the Common Rule would apply, and the assessment at that time was that CancerLinQ did not constitute research, even if the data are secondarily reused for research. So the idea being, if you collect it for QI to begin with, then consent is not required. I will say that this is a decision that we think about, and and may revisit. And we have at least one participating practice that has chosen to obtain signed written consent from all of the patients. And so we do require all of our participating practices to notify their patients, and there is a built-in opt-out mechanism if a patient does not want their data within CancerLinQ. To my knowledge, no patient has ever opted out of CancerLinQ in the last year, so there may not be that much of a need. As mentioned, our partner in this endeavor is SAP. SAP is the world's leading provider of enterprise software. It's actually the third biggest software company in the world after Microsoft and Oracle. ASCO developed into a co-innovation partnership with SAP. So what this means is that SAP brings the engineering expertise and the in-memory database platform, something called SAP HANA, H-A-N-A, that CancerLinQ runs on. ASCO, of course, provides the oncology subject matter expertise, and we're developing some applications together that others may be able to use. And the next couple of slides, this is the architecture of CancerLinQ. This is how CancerLinQ works. So CancerLinQ is software. It's software hosted in the cloud, and we establish a software connection with the back end of the electronic health record of the participating practice. There's an initial data dump, and then there are nightly incrementals. So the database is refreshed every 24 hours, so the data are very, very new. And this is actual protected health information that's brought into the CancerLinQ cloud. And it's in the form that it currently exists within the EHR. So there is no specified data form, there's no case report form that we require practice to fill out. They basically document in the EHR the care that they've been rendering, and this is brought into the system. The data then undergo aggregation and what we call statistical de-identification to allow third parties to query it. And then on top of the SAP stack, there are a variety of applications and services that are accessed by the user through a web browser, looking at quality reports and some of the things I'll show you today. And this is basically a slightly more detailed scheme of the same thing that at the bottom are the practice EMRs and practice management systems, and we use either a push or a pull technology to bring data into the data lake or the data staging area. Internally, we call that DB1. That's where the hard work for us begins, because we have to normalize the data, conform it to a standard data model, and apply vocabularies and ontologies. We're currently using the NCI Metathesaurus as well as some other vocabularies. There's a enterprise master patient index to minimize duplication and natural language processing and so forth. And then the data are landed in the clinical database. Internally, we call it DB2. And this is actual, each participating practice has their own clinical database, so they can see their own patients, PHI, specific information, and they can see their own quality measures. And then this important step in the middle is where the de-identification happens. This is through, we work with a third-party company from Toronto named Privacy Analytics using a tool called Parat. And that performs under HIPAA what's called the expert determination method. And the data are de-identified and aggregated into this much larger analytical database, which internally, to confuse you further, we call DB4. These are then accessed from the web browser, these various applications. What's new is actually over on this side of the slide here is that we have the ability now to spin off collaborator-specific private clouds. So a cloud of lung cancer, breast cancer, or by a specific biomarker and so forth. And we haven't done this yet, but we can add third-party data sets into this, like claims data or genomic data and so forth. And so what the tool does for subscribers, so all participating practices have access to the same suite of services. There's the quality performance indicators. There is a tool called CLQI, or CancerLinQ Insights, which allows the user to kind of drive through and drill down to smaller and smaller cohorts of patients to look for patterns and trends. There's this patient timeline for each patient in the system that can dynamically generate important oncologic milestones, sort of in a way. It's a data visualization tool that many times the EHR doesn't do very well, and then a variety of reports. We're using, this is a change. We originally were using an SAP product called Lumira, but we're now using Tableau. If you're familiar with Tableau, data visualization tool, it's very powerful and allows us to create some very helpful reports. So, a few words about implementation. I've talked to several of you this morning about this. The goal is to have minimal impact on your operations when we go live with CancerLinQ. And the reality is that most of the work is front-loaded. So there are no specific data entry requirements. We can connect with any electronic health record. The data is brought in its native form. It does not require any type of special form. We do the heavy lifting of the rules and ontologies. And the other point is CancerLinQ is free. You just have to have one ASCO member at any cancer center or practice, and there are no connection charges or no annual fees. The cost, if you will, is the cost of your team's time, IT, and clinical champions to help get it set up. But again, that's largely restricted to, this is a sort of an implementation timeline. I apologize for the busy slide, but really the onboarding process takes the first 4 to 6 months of a bit of back and forth to get the data elements right. And then there's just a series of sort of optimization. And, obviously, this is not, we set it and then we go away. We have product teams, implementation teams that work with our participating practices to optimize the tools and features and add custom reports to the system. So what is it that we bring in? Well, we since we're not trying to assign the data at the extraction phase to a specific data dictionary, it's really these very broad, we call them interaction types. It's really the important information that's in the electronic health record, and we just sort of put these in these huge buckets in the data lake, and then, as I said, try to make some sense out of these things. And it's really what's in your EHR. Many times it includes the historical data, so it may go back as long as you've had your EHR. I think Yale's been on Epic for several years now, so it would be 3 or 4 years, whatever it is, in Epic. I think probably we have the longest period of time we have for a center is about 7 or 8 years, since most EHR implementations are new. So just to say a word about quality reporting. So certainly there's been a tremendous focus on the requirements of MACRA and the transition from older programs like PQRS and the value modifier to the MIPS system. And I know Yale Cancer Center is doing the oncology care model, but again, this is the new world of quality reporting that everybody is stressing out about, because this is how we're going to get paid. And quality reporting is really an important part of what ASCO has been delivering through its older programs, through COPI, the Quality Oncology Practice Initiative, and other programs. And we're positioning CancerLinQ as an extension of that. So within the MIPS program, there are a set of oncology measures, and these will comprise a significant portion of the initial MIPS score. So this is what the payment's going to be built on. But as time goes on, this, as you may know, this is going to get more and more challenging for centers, because you have to report on at least 6 measures. One has to be an outcomes measure or a high priority measure. And this is the zinger right here. You have to report on 50% of your eligible patients for each measure. So for something like adjuvant breast cancer or something like that, ER-positive adjuvant breast cancer, if the measure is about did you give an AI, you have to show data on half or more of that. And that's very hard to do in the non-electronic environment. And the other kicker is it's not just Medicare, it's all patients. So your private payers too go into this calculation. Don't blame me, this is CMS, but these are the rules of the road. And so that's really where we're moving to position CancerLinQ. So starting with the COPI program, we had the same general idea that there were quality measures that are part of COPI, where we report on individual physician scores and aggregated scores at the practice level. But the big difference, the two big differences between COPI and CancerLinQ, COPI is purely manual right now, so you have to do manual chart abstractions, which is, of course, very labor-intensive and ultimately not sustainable. The second is that COPI and a lot of typical quality programs, they're all retrospective, and you select the charts that you're putting into the program. So to be honest with you, there can be some cherry picking of charts. You can pick the 25 prettiest breast cancer cases or whatever to go into the quality programs. You don't get that option with what CMS is expecting of us, And that's the way we're sort of designing CancerLinQ. To do this prospectively, it'll be all patients that qualify for the measure based on the data elements that are in the measure. But it allows us also to identify what we call actionable patients, so patients that are subject to a specific clinical quality measure but have not yet achieved concordance. So it's kind of an early warning system. You know, did you miss adjuvant chemo for a stage 3 colon cancer or something like that? And again, I won't read what's on the slide here, but this is a list of the current quality measures. They're all based on the ASCO COPI measures. And as I said, we're trying to pivot this now a bit to meet the MIPS reporting requirements. Initially, we started CancerLinQ before MACRA, and so we were focusing, Karen and I were talking about this morning, we were focusing on the COPI certification measures and other ASCO measures, and now since we're required to report on the MIPS measures, then we have to add these into CancerLinQ, and OCM to come. And so, you know, just a few quick screenshots of what this looks like. This is the main portal. Again, this is just running on a web browser through a password. Each of these tiles launches a specific application. These are all customizable. Whoops. These are the clinical quality measure. This is the clinical quality measure dashboard. I know the text is not particularly readable here, but each if you're logging in as a physician supervisor, you can see the performance of your entire practice or center, depending on what your user rights are, or you can see your individual performance rates. And these are all dynamically updating. So every day that you log on, the data that is behind this, that comes from your EHR, is updated from the night before. You can drill into each of these. Again, this is much more powerful in the live setting, but I can click each of these measures, and you can see concordance rates by physician and a number of other elements of the data behind it. And this is this CancerLinQ Insights tool. Basically, the way this works is you can point this either at your own patients or the de-identified aggregated database, but you can start with all patients, and you can say, I want to focus on non-small cell lung. I want to look at stage 3. I want to look at those over 70. I want to look at those that live in this county in Connecticut. I want to look in these with a specific biomarker. And then you can start looking through these various filters that are over on the left here. You can start dialing in different outcomes. Again, some of this is coming. It's not there yet, but this is the power of the self-service tool. And this is the patient timeline that I was talking about. This is these individual swim lanes here are the specific data behind this is in the EHR. And as time goes on, we're going to build out surgery and radiation oncology. And all of this, again, this doesn't show on a static slide, but if you can scroll with a mouse or a trackpad, these swim lanes shrink and expand. And you can click into each one, and you can see the data behind it. You obviously can only see this on your own, the patients in your own practice. You couldn't see anybody else's patients to do this. This is just what a Tableau report looks like. I know probably the text is not very clear, but this is some of the reporting. All of this is customizable. There are these click boxes off to the side. And this is really just looking at the 12 practices that are fully live right now. It's about 220,000 patients or so. And there are these heat maps. You can hover over each of these and click this, and you can see by region of the country. This would be a look at the aggregate data. And I know this doesn't project at all, but this was supposed to be the GI cancers, and you can break these heat maps into the individual cancers. And I blocked out the names of the participating centers here, but you can see within CancerLinQ, the informatics team can see which center is having which patients, and that will allow us at least to focus our efforts a little bit. So some pretty cool stuff. So there's no question that we have to prioritize the privacy and the security of the data. You know, ASCO is not a provider organization, and so we are taking in protected health information. So the pillars of data stewardship, protection, and transparency are essential for our success. And so to do this, we have a number of board-appointed oversight committees. We have, I think we had more attorneys in privacy and security working for CancerLinQ than informaticists when we got started, so we have a robust set of experts who advise us. We obviously have to have board-approved policies that govern how the data is used. And we have a requirement of making sure the data is of the highest quality. That's really a part of a data governance program, is quality assurance and availability. And so where are we to date in the 15 months or so that we've been live? So we've had a remarkable response from the oncology community in the last year. now in about 81 different cancer centers and practices. And when I say a practice could be multiple sites of service. So, for example, Intermountain Healthcare is 22 hospitals. That's one of our centers. That's 22 hospitals or so in Utah, and multiple sites count for one center. We initially focused on some of the community centers, largely because the lift was a little bit easier, and they were server-based EMRs, which were in the practice, so it was easier than a cloud-based system like Epic. But as mentioned, we have been with Epic. We have 22 Epic sites. Not all of them are live yet. And we really have not had a problem, thankfully, in connecting with different electronic health records. So really, any type of EHR that we encounter, whether that's a best-of-breed oncology system like iKnowMed from US Oncology or an enterprise system like Epic or Cerner, we've been able to do this connection. All told, it's about 1,800 medical oncologists participating in CancerLinQ practices right now. They've signed BAAs with us. So that's about 1 in 6 medical oncologists in the U.S. Our goal is to achieve critical mass about 1 in 2 in the next couple of years. And current trajectory, I think we're going to get there. And so again, this is just some of the centers. These are some of the academic centers that we've been with, Vanderbilt and Rush and University of Virginia, and some of the community centers. Catholic Health Initiatives is a very large integrated delivery network in the West. And just last week, University of Arkansas signed a business associate agreement with us. I would love to add the Yale icon to this, so would love to continue that conversation. So CancerLinQ is more than just a service for ASCO members and the patients in ASCO practices. It has always been envisioned as kind of a convener of the oncology community. So we have been in discussions with sister societies, with government and nonprofits and so forth, trying to bring in their thought leadership, to bring in their perspectives as members of the cancer care team. And actually, we have now memorandum of understanding with these organizations here. A few months ago, we announced what we call the Oncology Nursing Society Ambassadors Program. And so we're going to be working with ONS nurses who actually go out to CancerLinQ practices to help practices use the system better, but also to work on data quality. We also signed an agreement with Astro recently. And the CI4CC is the Cancer Center Informatics Group, some of you may be familiar with. And this is not officially announced yet, so don't tell anybody I told you this, but we're actually going to be working with SEER. This is specifically with SEER. We're going to be hosting the SEER public use file within the CancerLinQ interface. And we're looking to work with some practices that are in SEER reporting regions to do a pilot to use the CancerLinQ data abstract for the SEER reporting requirement. So we think that'll minimize some of the work that practices have to do to report to SEER. So stay tuned on that. So it's, of course, this is the obligatory Joe Biden picture you have to put in all of these talks. Makes me nostalgic, but certainly the time is right. The time was right last year as part of the Cancer Moonshot. We had tremendous support from the Vice President. We met with Mr. Biden on several occasions. He was very supportive of CancerLinQ as part of his effort. But really the emphasis was on data sharing. It wasn't just about discovery and speeding things up, but it was really the idea that we need to share data. And that's also part of the CancerLinQ vision. And again, I think there is this convergence now. Some of you may have seen this as an editorial sounding board in the New England Journal last week from Monica Bertagnoli about the time has come for clinical trial sharing, data sharing. It's important to honor and reward the altruism of patients who participate in clinical trials. Again, very lofty goal. There are many barriers we all know to doing this, but I think it's in this context that a clinical data set like CancerLinQ is now emerging. And so to that point, our latest effort really is pivoting somewhat from the quality improvement efforts to research and discovery. And this was a press release that we put out in November of last year talking about the development of what we're calling CancerLinQ Discovery, which is a research-grade database which will be opened up to non-participating practices, to third parties, whether that's academic institutions or commercial entities, to use CancerLinQ data for research. We also announced at the same time a partnership with AstraZeneca as our first enterprise partner who will help us support us in building up this, this database. And so what CancerLinQ Discovery is, it's really an extension of the main CancerLinQ database. So it's the aggregated, de-identified database that all participating practices get, but it has extra stuff, if you will. We're providing additional editorial and curation efforts to ensure that the data that's in Discovery is curated to the highest, or to the single canonical form, if you will. And that will require additional tools because of the quality of EHR data. It will require natural language processing and manual curation. We have always thought that the vision of this would be to feed this back to the main CancerLinQ database, so that this is not something that only some people get, that all users of CancerLinQ will have access to the same data elements. Since we can't boil the ocean, our initial focus will be on non-small cell lung cancer and breast cancer, focusing on going through manual curation of those entities with others to follow. And this is all enabled by a board-approved data access policy. So it took about a year or so, but the ASCO board and CancerLinQ board came up with an appropriate data use policy for third parties to access CancerLinQ data. And again, I won't go through this in complete detail, but the general principles are that the main analytical database is still reserved largely for subscribing practices, and no one has access to the patient identifiers or the practice identifiers. But third parties with a legitimate interest in CancerLinQ data can request access through this committee called the CancerLinQ Research and Publications Committee. Karen Adelson is a member of the committee, chaired by Gary Lyman. And the committee will adjudicate requests for data. And we can spin off, I showed this in one of the earlier slides, we can spin off these custom cohorts to answer a specific analytic question. And the delivery will be either a specific analytic report that our teams produce, or we actually can provision the data set in a cloud environment that we control, but the data requester can actually look at the data using approved software like SAS or R or something like that. And as mentioned, all of this, these are third parties, to be clear. The regular CancerLinQ participants already have access, although not to necessarily this research-grade database with the full set of tools. But this is going to be overseen by this committee. And really, I think this is something that we're just getting started with now, so I don't really have a track record to tell you how this is going to work. We anticipate there's going to be a lot of interest in access to CancerLinQ data. But the goal is really to say we want to free the data. We want to share the data, and the criteria for approving the data will really be, the primary question will be, does this improve cancer care quality? Does it further the ASCO mission? Is the data sufficient to answer the question, of course, is an important secondary question. So the committee will approve that, and then after the research is done, then we also have a requirement that the publication will have to be seen by the same committee. It's not peer review, it's really just to make sure that the whatever came out of the data set is consistent with the original request. So just to talk in the last part of my talk here about some of the challenges facing in this world of big data. Big data is defined in various ways. You may have heard of the V's of big data, the volume that exceed a traditional relational database, the variety, the multiple different data types, the velocity, the speed. But certainly the one that is the most important to focus on is veracity, is the idea of getting the data right. And EHR data is very dirty. It's a challenge to work with that. We all know this. The challenges are in oncology and probably in most fields. It's that too much is captured in unstructured forms, in text notes, through dictation. Key oncologic elements, so cancer stage, tumor response, progression, adverse events, are rarely seen in some places in the structured data elements. So that makes these enormous challenges of trying to aggregate this and query it. And we've tried to approach this systematically. We look at our data flow. This is sort of a map of the same thing I was showing earlier. And each of these places is an opportunity for us to try to improve data quality. So at the practice level, It's a matter of trying to make sure that the practice EHR is used in a way that optimizes data capture for downstream use. We look very carefully when we extract data through the pull mechanism. We have to get those mappings right. That can be a big challenge with thousands and thousands of tables in a big EHR like Epic. And then the transformations and the harmonizations. Again, the informatics team works very hard to take 25 different versions of LDH and make that a single canonical form, no small feat. And this is just an example. I just put this up there for interest. So, one of the questions is intent of chemotherapy. Is it curative? Is it palliative? Well, this is just, I think you can see that these are just some of the labels that we found in, this is only 12,000 lung cancer patients, but I don't know what all these things mean. I mean, this is what we found in EHRs. This is definitive. I guess I know what that means, but induction, DAST, action, palliative and curative are the terms that you see the most. But even if you add all these together, that's still less than 40% of lung cancer patients had the intent of chemotherapy documented. Now you can impute this from stage perhaps, but nonetheless, this is the challenge of big data. So how are we focusing on this? With every practice that we bring on, we have a multi-step iterative process where we show them their data and we go back and forth to understand whether there's changes they can make to optimize things. I was telling someone earlier today, it's almost when we show practice their data for the first time in CancerLinQ, it's almost like Kubler-Ross stages of death and dying. There's denial that my data couldn't possibly look this bad. You guys got it wrong, and then there's bargaining, and then ultimately acceptance, and so things do get better after time. We've also been working closely with this company called Evidera, which is a commercial health economics and outcomes research company, data analytics company, and we made a transformation of the data model from the quality data model from CMS to something called OMOP, the Observational Medical Outcomes Partnership, which is more amenable to sort of research grade queries. And finally, we are looking at the use of NLP. So natural language processing is a technology which has not arrived yet. It's not fully in prime time, but it does allow us to focus on specific areas of interest, and the priority domains specifically are these things down here. It's staging, biomarkers, adverse events, and progression. These are concepts that are not well represented in the electronic health record and structured data, as important as they are. And we're going to limit our NLP focusing on clinical notes, surgical pathology reports, and imaging reports, because that's where the interest is. And if you kind of look how these systems perform, this is just from a systematic review in the Journal of the American Medical Informatics Association. Even in more recent times, the sensitivity of these NLP systems trying to pull out existing classifications, like just pulling out ICD-9 codes from text notes, it's pretty lousy. I mean, you can see, perfect sensitivity or recall would be 1.0, and you can sort of see the range here. So how are we handling that? Well, we are using NLP to assist human curation, so manual data abstraction. And this is the same sort of data flow that I keep showing. This is sort of the top is the way that the CancerLinQ data flow is working right now from the EHR into the various databases. But what we're doing down here is we're working with a couple of vendors, and we have an NLP engine that is running in a workbench. And so the documents with the putative data elements of interest of those four main categories, biomarker, staging, progression, are going to be presented to these teams of human curators. We call this nurse language processing. The nurses here will be pulling out the data elements and feeding that into the structured data, and that will flow back into the database. So this is something that's just getting started. If any of you have been working with Flatiron, I know you've been with them for a number of years. This is something that they've been doing. I must say, I hope, next year if I give this talk, I hope I don't have to show this slide, because, this is expensive. If you think about it, it's nonsense. We're basically taking structured elements like a cancer stage, it goes into a note, into a dictation, and now I got to pay people to pull it out again and put it into a data flow. So, but it's really the only way to find things right now. So there's been a lot of interest in optimizing the use of real-world evidence. the FDA weighed in. This was an editorial from Rob Califf at the end of last year talking about how RWE will be used for regulatory decisions. And there are many sources of real-world evidence. This is CancerLinQ EHR phenotypic data is one example, but claims data sets and even things like wearables and social media could potentially be brought into a big data platform like CancerLinQ, and important questions answered that way. Again, to be clear, we're not doing this yet, but the infrastructure, the SAP HANA platform allows us to bring in these diverse data sets and query them. And this is something that ASCO has been weighing in on as well. This is a publication that's actually coming out Thursday of this week, talking about the untapped potential of observational research to inform clinical decision making. Many of the authors here. And sort of comparing and contrasting the value of randomized clinical trials. This is, of course, the world we live in compared to the world of RWE. We all know the advantages of clinical trials. Probably the most important is the strong internal validity and the fact that trials will show efficacy. They show what can work. But the disadvantages, of course, are well known as well, that they're slow and costly, and they fail to capture important long-term outcomes and so forth. On the other hand, real-world evidence has strong external validity. It is responsive to changes in practice. It reflects real-world effectiveness. And this is what you're seeing. You're seeing how drugs are actually being used in CancerLinQ. The disadvantages, likewise, the data are incomplete. We've talked about the data quality. You can't blind or use control groups in an RWE data set like CancerLinQ. And probably the biggest is bias, is that you can't easily control for these biases. Selection bias, how were the patients chosen for the therapy? Detection bias, what if in a clinical trial you do a CT scan every 2 months? The CT scan is done however often the doctor decides it's going to be done in data sets like CancerLinQ. So how do you answer that? And these are some of the recommendations from this ASCO paper, basically speaking to the importance of a more concerted effort, starting with the Office of the National Coordinator and specialty societies to improve the quality of electronic health record data available for research. Can't speak to the importance of getting it right in the intake phase. We all know the challenges of interoperability, but there are opportunities to improve this now, as well as all along sort of protecting patient privacy. So what do you believe? Well, I think you obviously need both. You need real-world evidence to complement and be harmonized with the evidence that comes from clinical trials. But there are many challenges, and these are the things that the CancerLinQ teams are starting to work through. I think probably the biggest, and I'd love to hear people's insights on this, is how do you define these endpoints? Survival, time on treatment, progression, response rates. It's just not the same thing in a CancerLinQ data set, but there's important information in there to be brought out. And so how can CancerLinQ be used to service some of these questions? Well, I think probably the most easily identifiable use case is comparative effectiveness research and looking at important questions that can't easily be answered by clinical research studies, comparing different modalities. Certainly, post-market surveillance is another use case for CancerLinQ. How are the drugs being used in higher risk populations? There's also the opportunities for clinical trials facilitation. CancerLinQ can help identify target populations and the frequency of whether it's markers or specific anatomic diagnoses, and can suggest places where studies may be focused. And again, I won't spend time on this, but I mean just some of the use cases that we've thought about. Again, to be clear, we're not ready yet to be able to deliver on these, but we know as the data quality improves, particularly for non-small cell and lung, these are the kinds of questions that we'll be able to answer. I've had some great conversations with Lajos about a comparable example in breast cancer. So I think that there is this new universe of possibility. The world of big data requires us to do things in different ways. We all love to hate in information technology because of our experience with the EHR, but I think there's opportunities to get it right. And so, in summary, what makes CancerLinQ unique? I think first and foremost, CancerLinQ is created by oncologists for oncologists. CancerLinQ is created by ASCO, the Professional Society for Oncologists that take care of people with cancer whose primary mission is improving cancer care quality. CancerLinQ already incorporates ASCO coping measures and guidelines, and ultimately the time is coming where we'll be able to inform the development of the guidelines by the real-world evidence that's in CancerLinQ. The CancerLinQ data set is evolving into what we believe is becoming the most robust, the largest and most robust source of real-world evidence ever assembled in oncology for comparative effectiveness research. And I've had some great conversations with many of you today about some of those opportunities. And ultimately, CancerLinQ is guided by ASCO's mission to support all physicians in every community, in every setting. So right now, CancerLinQ is used for quality improvement and compliance, used for data visualization. This is what every subscriber gets. Research and discovery is coming, and I think this is where the real excitement of big data will be borne out. So we're really looking forward to working with colleagues at Yale and other places for this. So I'll stop there. Thank you very much for your attention.